My name is Kamil Cornett, and this is the Journal Club review of my paper. The purpose of this study was to investigate whether surface EMG is a valid metric for estimating gluteal muscle forces during hip-focused exercises. Uh, the significance of this study was to challenge previous clinical assumptions in sports performance, injury prevention, and rehabilitation. Uh, Professionals often use EMG to determine how effectively an exercise targets a specific muscle. This study highlights that as a misconception. The primary research question, it was to assess the influence of using surface EMG compared to OpenSim force estimation to rank gluteus maximus and gluteus medius resistance exercises. Secondarily, they wanted to examine the linear relationship between EMG amplitude and muscle force under two different analytical concepts. Research is thorough in nature. It provides a clinical baseline from the study Netto 2020. The baseline is provided from this paper because it collected and synthesized over 70 standalone EMG studies. It also establishes a state-of-the-art modeling justification of methods by citing Rajo Gopal in 2016 as justification for OpenSim. It's relevant. It includes literature on the EMG, specifically F. Testal 2016 that shows mechanical tension, not activation, is what triggers the muscle protein synthesis, and it justifies the study as well. They justify the exercise selection with the study Ford 2015, and they justify their EMG processing protocols. The subjects were 14 healthy female footballers with a median age of 24.1, a median weight of 62.6 kilograms, and a median height of 169 centimeters. The inclusion-exclusion criteria includes they must have played competitive soccer, they must be between 18 and 35 years old, must possess minimum 3 months of experience in lower body strength training, and they must have never had lower limb injuries. The sample is definitely appropriate, but it has low generalizability. Uh, that is because it's highly representative of young, healthy, active, resistance trained female athletes, but that's not indicative of the whole population. Potential selection bias includes the fact that, well, this study was previously conducted and that the data comes from a cross-sectional laboratory study from 2021, and the authors did not perform a priori power analysis. There also might be a healthy volunteer bias, which is all of the samples, since they never had lower limb injury, are considered a hyper healthy population. The methodology and design. The study utilized cross-sectional laboratory-based design. The procedure was they did pre-testing, which was 7 days prior to the main biomechanical testing, where they tested the participants 12 rep maximum. Then on the day of the testing, they did a warm-up, which it was 5 minutes, included cycling, walking lunges, stretches, stuff like that. Then they did a normalization baseline, which following the warm-up was participants performed 7 distinct maximal voluntary isometric contractions to establish a maximum activation baseline. Uh, then they did the exercise execution, which was the actual testing. This included 8 exercises, all revolving around hip flexing. The loading conditions, they were performed using only body weight only and the 12 rep max that was predetermined on that 7-day previous period. Collection. For kinematics, the full body movement tracking was recorded at 200 hertz, and it was done using a 3-dimensional camera. The kinetics was the ground reaction forces were recorded at 2000 hertz using force platforms embedded into the ground. The surface EMG was recorded at 2000 hertz using a wireless system, and they used standardized skin preparation, which was shaving, abrading, and cleaning the skin. They used 12 electrodes. The raw EMG signals were mathematically processed into linear envelopes using bandpass, low pass, and zero lag Butterworth filters and full wave rectification. The data was analyzed using Spearman's rank correlation coefficient, and they defined anything under 0.7 as poor agreement. That was for the primary aim. For the secondary aim of the study, they wanted to look at how confounding variables warp the interaction between muscle activation and force. So first they used the EMG alone, which was measured using raw R-squared values to compare the raw data to itself. Then they did EMG plus the specific exercise, which accounted for the random biomechanical changes in angles and positions. Then they looked at the EMG plus the individual participant, which accounted for different individual body impedance or variation in electrode placement. Finally, they combined all of them and measured using R squared to observe total variance. The appropriateness of the statistical tests, Spearman's is definitely appropriate because the guidelines that they set are fundamentally categorical and hierarchical. And since it doesn't revolve around raw linear values, a non-parametric rank correlation is the correct statistical analysis to use. And traditional linear regressions assume that all points are dependent. However, this is not the case for this data. There are interdependent data points, and that requires the study use tests like linear mixed effect models to handle this repeated measure structure. Then they ran a sensitivity analysis to ensure that the small adjustments that the software made didn't skew the data. Here for some of the results, they found that for the gluteus maximus, the Spearman's correlation coefficient was 0.29, and for the gluteus medius, it was 0.51. This means there's a poor agreement, so there's a failure to reject the null, and EMG is a poor metric for measuring muscle force. Now, the EMG to force relationship, looking at the raw EMG data, the EMG accounted for only 5% of the force in the gluteus maximus and 19% in the gluteus medius, but when it accounted for exercise and individual participants, it jumped to 80 and 85% respectively. Just the results displayed from the previous slide, but I do want to talk about the figure. These are figures 1 and 2 from the paper. Figure 1 depicts the gluteus maximus on the left and the gluteus medius on the right, and the hierarchical rankings of the EMG and the muscle force and how they differ. It's really just a visualization without as much jargon of statistical analysis to display how there's a disagreement between the two. The second chart is a different display, but it essentially points out the same thing, the disagreement between the muscle force simulation and the rankings by the peak EMG. For interpretation of the data, the reason that they account for this low group level variance is because the EMG can't account for the dynamic exercises and constant biomechanical changes. But they did want to point out that the EMG is not useless. It just needs adjustments to aptly provide useful information. And that includes, in this context, the specific exercise and the individual participant. Some limitations are musculoskeletal simplifications that were placed in this. They used the outer dimensions of each participant. They didn't use their skeletal structure or muscle insertions or anything like that. As for the software, it does execute tiny mathematical adjustments, which could account for some of the variance disparity. And lastly, it was not heavily focused on as a limitation, but the sample creates a sort of boundary because the sample is not necessarily indicative of the entire population. The significance. Firstly, what it does is it deconstructs a core clinical assumption. Clinicians, researchers, rehabilitation specialists, a lot of them use the assumption that EMG is inherently effective for doing things like muscle activation, or not muscle activation, is effective in that, but doing things like force and tension, and this study proves that it is not. There is a risk involved if patients of rehabilitation specialists are prescribed the wrong exercise. So really what they're doing is they're redefining what the EMG tool could be used for. They contribute to the body of knowledge by connecting the activation to tension. They also give specific standardized procedures, and they use literature and proven methods in their study. Some of the questions raised from this study are if the EMG and muscle force rankings disagree, which metrics are actually important for certain clinical applications? And also, since the study was only conducted on hip muscles and its related exercises, do vastly different muscles also exhibit the same 50% ranking disconnect between EMG and muscle force?